Got it. Share screen. This one. Share. Let's move that up. Okay, so today we're just going to swap up how we do the pair programming. So this is what we did last week. So students, blue S, and drop-in tutor, typically me and Diane drop in with our Mary Poppins umbrella. And we do this students drop in, and then we have the tutor demonstration. And then we want you to think about what has been best for your learning. And we're going to compare this with A/B. The other way that we're going to do it is we will demonstrate the model answer to the whole group first, and then you'll go into your breakout rooms and discuss the features that you're meant to find amongst yourselves with a drop-in tutor. And I want you to reflect about what's best for your learning. Now, just to be careful about what's best for your learning, I understand this is self-report. Often people don't know what's best for their learning. They choose what's easiest, but what's best for your learning is probably what's going to help you recall and remember the most. Learning is hard, so I'm not asking you what's easiest. I'm trying to get you to think about what's going to be best for your recall. So that's how we're going to do the breakout rooms today. Some A, some B, and we're going to swap it up. So it's a randomized controlled trial, but it's not placebo. It's a crossover trial.
Okay, so I will start. And today I'll share screen once my computer just like behaves a bit. Here we go, sharing the screen. All right, so today we're going to learn about tumors of the orbit. And here we go. So this is from a previous exam where we have a 14-year-old presenting with previous proptosis over the past 9 months and a CT suggesting optic nerve glioma. And the questions are, what are the histologic features of optic nerve glioma and what's the histology of the main differential diagnosis? So in an optic nerve glioma, I've written here the keyword explanation, okay? So a proliferation of pilocytic astrocytes with Rosenthal fibers that enlarges the nerve. So there's a few unusual histology words here. So pilocytic. Amanda, pilo means hair follicle, doesn't it? Hair, yeah.
Yes.
What are hairs doing in the optic nerve? Want me to answer that more myself?
Well, I can see things that look a bit hair-like, and they're not the Rosenthal fibers.
Are they these things here? They're the kind of long, strandy things that are the Rosenthal
things
fibers.
like this. Yeah.
Yeah. So
but wiry.
That's right. So the neurons are growing. So there's a nucleus and they've got long cell processes out. And mostly they grow that way because of the architecture in the optic nerve. So they're growing as long processes, and they resemble hairs, and we call them pilocytic. And there's a whole class of pilocytic astrocytomas that describe this long hair-like growth. And Rosenthal fibers, the Rosenthal fibers are indicated here. So I think of them as constipated nerve fibers. They just become plugged up. They don't transport anymore. They kind of look like spirally carrots, and they are bright red, and they are a feature of these pilocytic astrocytomas.
Diane, can you make that full, what do you call it?
I'll try and make it full screen. There we go. How's that?
Yep, that's better. We can
Rosenthal fibers. Yep. So pilocytic astrocytomas can occur in other places in the CNS, and all of them are very low grade. So all of them are grade 1 tumors, which means that they grow but don't metastasize. But as we know from our understanding of the brain in a confined space, even if they just grow, people get into trouble, and they can destroy structures like the optic nerve. And the other all right, so here we go. Let's have a look at this path presenter.
So now we're doing model answer first, right?
Yep, doing the model answer first. And I actually have this preloaded, so I will just change here. I've just got to move my control bar a bit. Here we go. So here is this path presenter. So this is an optic nerve here. And do you want me to drive and you to describe, Amanda?
Oh, okay. Yes.
Or do you want me to, I was just thinking modeling pair programming.
Yeah, yeah. So you've got the mouse and you have to drive then. I can't drive, okay. I have to navigate. So just at low power here, because the first thing is identify the normal. So I can see a sort of a C-shaped structure. And I can see there's some, it looks like, well, I can see there's a core and then there's a covering and then there's some loose coverings on the outside of it. So I'd probably start with the core and identify the normal structure, and then I'd work my way out and identify what's normal and what's abnormal structure. So
what do you think this is here?
Well, that could be part of the cross-cut end of the core thing that I see at the other end. So, yeah. But I see a complete loss of structure when I compare. So on the right side, that core of material, perhaps you'd like to indicate that with the mouse. Yeah. Yes, I can see it's got packeted structure, and this looks like what an optic nerve packets of nerve fibers look like that are intersected by fibrous connective tissue. And I can see lots of little purple cracked items in there. Yep. And I would wonder what they would be. Perhaps you could have a closer look for me.
Yep. There's some, we'll go.
Yep. Little round things, and they look cracked, and they're clearly hard, and they're fractured during the sectioning process. And I saw some before, and they sort of had like little laminated rings around them. They look like little calcifications to me, like Simoma.
Yeah, they do, don't they? Bodies. So we've got some little calcifications here, haven't we? So they look like Simoma bodies, probably.
Yeah. And then I would relate, because you were talking about what was at the left end of the specimen.
Yeah.
So that looks like optic nerve, optic nerve structures. And then we sort of cut through, it sort of goes in, and then this should be optic nerve, but it doesn't look right to me.
No, it's got all these whorls again, but these look like a different set of cells, don't they?
They do. They're more epithelioid type cells, and they don't look like the same cells at all, and they don't have that structure. So those whorls, the things that do whorls to me would be meningothelial cells.
Yeah. So what are they doing there? I wonder. So so just revising that, we've got this central core, which has got calcifications in, and then we've got this thing here.
Yeah, and then the coverings of the optic nerve seem really, really thick to me.
They are really thick. Yeah, they are really
thicker than I would normally expect of an optic nerve. So I know there's pia, and then there's arachnoid, other layers. And then, well, what's in here? So it looks, it's been thickened, it's been expanded by a proliferation of cells.
I think this is showing one of the tricks that you get with optic nerve glioma, is that you can get reactive proliferation of the surrounding meninges. So I happen to know that pilocytic astrocytomas are associated with calcification. So I wonder if there's a whole lot of pilocytic astrocytoma growing through the optic nerve here.
Because, according to my book, calcifications are not a normal part of the optic nerve.
That's right.
If you think of all your radiology, when do you ever see calcifications in an optic nerve? So there must, and it also looks very, there's a lot of, looks like salt and pepper. There's lots of little extra nuclei in there to me.
So I think probably here we might be seeing the long hair-like processes here. But I haven't seen any Rosenthal fibers. And then we've got some reactive change around the outside, because this, what does this look like? This actually looks like a bit of fibrous tissue, doesn't it?
It does look like a bit of fibrous tissue. It does have blobs in it. I wonder.
Yeah.
I wonder if there's been some infiltration of the glioma out into this area. Could some of those dark areas be Rosenthal fibers?
Yeah, I think they might be. And then this looks like glioma out here, more
Yes,
traditional glioma, doesn't it?
because they look like fried eggs to me. So if you cut one of those spindly cells, on transverse section, then they could look like that. So I'm suspicious that this has got a neoplastic component in it. That looks like a Rosenthal fiber.
Yeah, here we've got some Rosenthal
Yes.
fibers here and here and here. So, and then on the outside, we've got the meninges through.
Because that doesn't have the whirly bit that you showed me before on the left side.
No, I reckon this might be meninges though. And then we've got some meningeal hyperplasia maybe.
Yes.
Out this way. So
Yep.
I reckon this is a really good example of what meningeal hyperplasia looks
yes.
like.
That bit there with the whorls. So
we've got, yeah.
How do we know it's not a meningioma? They do whorls too.
They do, but I think in a meningioma you'd just get compression of the nerve and wouldn't get the calcifications, eh? So
we wouldn't be able to explain the calcifications in the nerve without the whorls.
So I think we've probably got optic nerve that's encased by glioma and probably infiltrated, causing the calcifications. And then out here, actually out here, we've got some really good examples, particularly in this layer here where it's all cobwebby of Rosenthal fibers.
Mm.
All right, should we pop the students into breakout groups now so they can look at it themselves?
Yes, and we should, in breakout rooms, perhaps discuss further things such as special stains, ancillary tests, and what it would look like in radiology. A, B, C, D, E, F.
Yep, let's do that. So Reza and Amanda, I'm going to move you around some rooms and you can discuss some of those things.
Oh yeah, and there's some things coming up on chat. Have to open up the window.
Oh, good.
Oh, show the pia scepter. Oh yeah. And we can show you want to zoom in and show the septal pia scepter in the optic nerve, dividing it up.
All right, here we go.
Yeah. Which if you Google up normal optic nerve, you can see it's divided up into these packets.
Yeah, this is them here.
Yeah, and just the optic nerve itself. So it's not just a whole bunch of wires. The wires are divided up into packets, which is the septa, which is the fibrous structure that holds the optic nerve together. Yeah.
Yeah. Is there anything else in the chat?
That's it.
All right. Right. Breakout rooms. How many people have we got here at the moment? We've got 23. So I might have put you in 7 breakout rooms and then move us around.
Mm-hmm. Okay.
Right. I'm going to assign you automatically. Open all rooms. Off we go.
Room 6.
Move to 3. All right. So Ginny, how are you up in Hawke's Bay for the next 6 months?
Yes, 6 months.
And you moved from
Palmerston North.
Palmerston. All right. So is the Palmerston North Hawke's Bay like one training unit, or do you go to other places as well?
Oh no, it's a separate training, separate centre.
Yeah. I've been to the new private eye hospital where my dad was having his cataracts done.
Oh,
It's pretty nice in there. I've never been to the hospital eye clinic.
oh, okay. I'll find out on Monday.
You will, yeah. You'll like living here. It's just gorgeous. I'm gonna put my foot in it, possibly with the Palmerston North people, and say that you'll like living here more than in Palmerston North.
Oh, good. All right. Shall we address any group questions, Diane, before we move on?
I thought that was quite a difficult slide. It took me a little while to get orientated into where the tumor was and wasn't and things. All right. So, all right, participants, chat. Any group questions on the chat?
Yeah. It just stops everybody talking over each other, because we can always call on you to verbally talk about it. But if you can just say that you want to say something, then we can call on you. But otherwise, okay, right. Can we go through the immunohistochemistry and CT findings? Oh, you guys are good at CT findings. And yeah,
we're going to do a meningioma next, so we'll learn about that. All right. Yeah. So, okay, can we explain the rules again? All right.
I'll go and find a normal optic nerve while you're doing that, because this seems to be the
problem. Can we go through staining, IHC, and CT findings? All right, someone be brave and tell me what an optic nerve glioma looks like on CT.
The fusiform arrangement with diffuse enlargement behind the globe.
Great, perfect. Could you see that was kind of fusiform, vaguely? Looked a bit like a...
Oh, it does look like a sausage to me.
All right, there's a bit on the left that was narrow and a bit like, anyway, yeah, so it's fusiform arrangement. So I was talking about to some groups the IHC. So in modern neuropathology practice, we want to do IHC to confirm the type of tumor, because often there's specific mutations that are associated with different tumors. And then we want to do IHC for prognosis. So the IHC that we do for just about all gliomas is one called IDH1, which reflects a mutation in the IDH gene. And the IDH gene is mutated in the ordinary common or garden astrocytoma. And it's not mutated in pilocytic astrocytoma. So if we saw something that looked like a pilocytic astrocytoma, and it was IDH1 positive, we'd go, whoa,
that would be unusual.
That would be unusual. We'd go and we would go, maybe it's not one of those, and we would go looking for other mutations. IDH1 is also useful for telling glioblastomas of primary origin away from others. So can anyone think of an immuno that might be useful for telling prognosis in these tumors?
I read a little bit about like neuron-specific NLAs. Is that something that you use, or is that incorrect?
So NSE would just tell us that it came from neurons, and so we know that this is an astrocytic tumor. Yeah, so Bobak's saying Ki67, so that is a really useful proliferation index marker, and that would let us know the prognosis of a tumor. EMA is quite useful in telling meningioma from astrocytomas, because EMA is positive in meningioma. GFAP, glial fibrillary acidic protein is positive in both of them, because they're both meningeal tumors. But just remember, immuno for tumor type in particular. Now we look for mutations, and immuno for prognosis. Why is the calcification blue? That's because it is attracting the hematoxylin, which is a basic stain. And so the calcification must be slightly acidic. And what other questions were there?
I was trying to find a nice optic nerve so that we can look at a optic nerve that's normal.
So Jess asked, other than the calcification, is the central structure of the nerve normal with the packet arrangement? Basically, yes.
Yes.
There's been some infiltration, but the packet arrangement is still preserved.
That's right. I'm just trying to find So, oh, here we go. If I'm going to do a screen share, and here we go. I found another case. This is something else, but we're looking at the optic nerve, and it's cut in transverse section now. There's nothing really wrong with the optic nerve. We've got the central retinal artery and vein, and we can see this packet structure in a normal optic nerve. So those are the pia septa. And then around it, we have the arachnoid and pia, and then we've got the dura outside that. So this is sections of a normal optic nerve.
That's really beautiful.
It just looks like it's cut accidentally because, you know, that's perfect, isn't it?
It's gorgeous. Yeah.
So pia, arachnoid, dura, and all the little bits in between. These are the glial astrocytes here, normal.
Good. Should we give everyone 5 minutes to look at the next case now? We'll do the A-B swap.
Okay, so we'll do the, yep. Breakout rooms first, stop share.
Yeah, so I'll put everyone in breakout rooms again, and we're going to go to the next slide here, which is the meningioma. So we're looking for bland meningeal cells arranged in whorls with psammoma bodies. So I will open up the breakout rooms again, and you can all have a look at that for contrast. 5 minutes, people, 5. Right, I'm going to remember to press record. Excellent. We are recording, and everyone will come back. So yeah, so that was a good example of tons and tons of psammoma bodies in a whirly meningothelial tumor. Okay, are we all back now? We have question times in the chat. All right. Do you do all right, so that might have been from, do you do IDH1 and EMA to distinguish from glioma? So
Oh, somebody's got a bit of background going on.
Yeah. So for meningiomas, like 99% of the time, they just look like meningiomas because they've got whorls in them. If we're ever stuck, then we do an EMA and a GFAP.
And the IDH1, I never do an IDH1 on optic nerve gliomas because, well, it's the wrong sort of tumor.
Yeah.
So.
Yeah.
EMA goes with the meningioma, that's reasonable to say. But remember, meningothelial proliferation will also be EMA positive.
Yeah. So the surgeon will help you because he'll take the lump. And quite often we get like a lump from meningioma. What's the role of vimentin and cytokeratin in meningioma? I don't use either of those. So no.
They'd probably both be positive. Not helpful.
Right, so okay.
With
so,
that pilus not in pilocytic.
Yeah. So Bobek's question. Yeah, so yes, we use Ki67 for identifying more aggressive behavior in a glioma. EMA will differentiate meningioma, and I don't use S100 to do with anything in the brain because every single thing is positive.
Because you know what S100 was originally made out of? Ground up cow brain, the whole thing. So it's any antigen of neural sort positive.
No, I didn't know it was made of ground up cow brain. Oh yeah.
There we go. Bovine cerebral
Right.
extract.
So should we quickly go through that slide like we said we were probably going to do?
Yes.
I will share my
answer.
screen. Okay, share screen, Diane. Path presenter, share. All right, and we'll go full screen. Okay, here we go.
Okay.
So do you think there's any normal there, Amanda?
Looks like multiple fragments of tissue to me that has been curated out. I can't actually see any normal structures.
Oh.
Looks like multiple fragments. I don't have an architecture to guide me for normal structures. And that's why it looks like multiple fragments to me. So that's okay. And that's how I describe it. Multiple fragments of tissue composed of, and then I go in closer and see what it's composed of. Composed of looks like spindled cells arranged in concentric whorls. And I'd even look at this and I'd say, look like meningothelial whorls. Lots of them.
Yep. What are these cells here, Amanda?
Oh, in between. Well, maybe we'd like to have a little closer look at those. Well, they look somewhat similar.
They look like the cells whirling around here too. So we've got.
But they're just straight.
Yeah, so we've got fibrillary meningothelial cells and whirling meningothelial cells.
So what was that word? Fibrillary.
Fibrillary, yeah.
Yeah, like fiber.
Yeah.
Fiber, as well as whirled.
And this is nice, isn't it?
It's beautiful. It looks like, tree trunk sort of thing with concentric laminations or concretions. And it is like a little concretion of a stone, but it's calcium and it's a psammoma body. It's not a cell. Some people were describing them as cells. They're not cells. Calcium is not a cell. It's an extracellular, it's a mineral. Yeah. And they probably occur in the center of those concentric meningothelial whorls. That it's the nidus.
That's right. They become calcified. It's an example of dystrophic calcification almost, isn't it? Yeah.
And then regarding prognostic factors, I'd have a look around to see if there's mitoses, but at first impression, because there's so much psammomatous calcification, I would think it's been here for a very long time. Didn't see any mitotic figures at all.
Oh.
So I think this is low grade, slow growing. So I would think this is just in the meningioma category, because I'm also thinking, is it atypical meningioma or is it malignant meningioma? So, meningioma, atypical, malignant. I'm back at the meningioma end of the grading.
Yeah, so grade 1, the lowest grade. Yeah. Yeah. Okay, let's just whip back to the PowerPoint. Where are we here? PowerPoint. Okay. I'll just go up a bit on PowerPoint.
Okay.
All right. Okay. Right. Here we go. Right. So we're going to move on from the PowerPoint. Sorry. Oh no, that's gone forward.
Oh, yeah, other way.
Come on, PowerPoint. Go backwards.
Or not the end.
Right. So we talked about the optic nerve meningioma. So now we're going to think about other things that happen in the orbit. We're going to think about lymphoma. So the typical lymphoma questions that you will get will be ones that ask for differential diagnosis, ones that ask for laboratory procedures and investigations. So here's a couple of very typical questions that you might get. So remember we were talking about topic, task, and limitations. Describe, so the topic is a lacrimal gland biopsy for suspected lymphoma. The task is to describe the range of specimens and laboratory tests that may be employed in it. Yeah. And then here, again, we've got the topic, which is lymphoid tumors in the orbit. All right, so all kinds of lymphoid tumors in the orbit, and we want to discuss the spectrum, and they give you the list of topics that they want you to discuss for each lymphoid tumor. So that's the typical exam question that you will get. Here we are. So what is the spectrum of lymphoid tumors? Well, basically they are benign tumors, atypical. So benign tumor, I'm using the word tumor as a mass. Benign tumors are reactive follicular hyperplasia, atypical lymphoid hyperplasia, and then malignant. So I've noticed I've put non-Hodgkin's lymphoma there for malignant, but not Hodgkin's lymphoma, because really Hodgkin's lymphoma doesn't occur outside the lymph nodes. So all these are what we'd call extranodal lymphomas. They're occurring outside the lymph nodes, and they go, as many things do, from benign to atypical to malignant. So how do we tell them apart? Okay. We've got a clinical question here, actually. What's the differential diagnosis for suspected lymphoma of the orbit? Please type in the chat. I want to know the clinical differential diagnosis for lymphomas in the orbit. Well, what's an IOID?
Idiopathic orbital inflammatory disease.
Oh, thank you. And the GO?
That Graves or thermopathy.
Oh, okay, thank you. All right, so we've got inflammatory diseases like IgG4, Graves, and idiopathic inflammation. Yes, sarcoid, yeah. Granulomatous disease, reactive lymphoid hyperplasia, TB, possibly, yeah, TB. What else? What other tumors might I get? Yep, solitary fibrous tumor, rhabdo, eosinophilic granuloma. Yep, by which you mean histiocytosis X, if it was in a child. So any other tumors that might look like a solid tumor in the orbit? Would you ever mistake on the CT, metastasis, good idea. Would you ever mistake it could be a neuroblastoma. Would you ever mistake a hemangioma for a lymphoma in the orbit? So Carl, I was thinking more of the T1, T2 weighted image thing, because radiologists are pretty clever. The neuroblastoma is in young children, so possibly wouldn't think of it. Could lymphoma occur in young children? Usually in the orbit, it's in older people. But I would have thought they would have sorted out the vascular ones versus lymphoma because of the clever Doppler ultrasounds and CTs, yeah? And similarly, no one's written lipoma because fat's got a completely different look on radiology. Right, so we've got a differential diagnosis, dermoid. So the differential diagnosis, no, that wouldn't work because of the radiology. Differential diagnosis is solid tumors and variations of reactive and inflammatory, right? So those are the three categories, possibly infectious. Okay, so we are going to discuss these a little later. So let's have a look at benign reactive lymphoid hyperplasia. So this is what normal lymphoid tissue looks like. We've got these follicular centers. We've got this surrounding cuff. And then we've got here, we have got the area where the little vessels are here. Now, so let's have a look what words I've discussed here. This is the lymphoid follicle. The lymphoid follicles are composed of a germinal center and a mantle zone that surrounds them. Okay, if we look here, we've got these little things here full of dots. These are tingible body macrophages, where the macrophages have broken up bits of cells and are busily ingesting them. And if we did flow cytometry, which is a key investigation, we'd get all kinds of mixtures of cells here. We get the T cells and the B cells, and the B cells would show both kappa and lambda, so it's a non-clonal proliferation. And again, for immunohistochemistry, we can do immuno for oncogene markers, yeah, like BCL2, and they would be negative. And again, immuno would show kappa and lambda. So those are the critical investigations that we do to tell benign from malignant. Oh. Okay, so here we go. So this is what malignant looks like. So the typical tumor that you will find in the orbit is either going to be a MALT lymphoma, MALT standing for mucosa associated lymphoid tissue, or a standard non-Hodgkin's high-grade follicular lymphoma. They're the two most common ones. So MALT lymphomas are a low-grade lymphoma, and we get this uniform infiltrate. It's not quite uniform because some are bigger than others. Quite often they've got this weird plasmacytoid look to them, where we've got quite a lot of cytoplasm in them. Okay. So flow cytometry will show this, a monoclonal. That means there's only one type of cell present. They're B lymphocytes. Okay, so the B lymphocytes have this on the surface, CD20, that's detected in flow cytometry. When the flow cytometry says they're kappa restricted, right, Reza, are you there? Reza, can you tell me? Oh, good, because Reza's done this more recently. My understanding that kappa restricted means that kappa isn't present. Is that right?
Yes.
Yeah, it's a weird terminology I've always found. Kappa restricted means there's only lambda. Yeah, right, and negative for T cell markers. So this might be a typical flow cytometry thing, right? Immunohistochemistry, we might say we confirmed the B cell proliferation, and it's positive for BCL2, which is an oncogene. Now, BCL2, Reza, can you remember what that does? Because I've forgotten.
BCL2 for multiple lymphoma, it doesn't, for the follicular lymphoma will be positive, but for the reactive, as you mentioned before, is negative. And the positive BCL2 in multiple lymphoma, I don't think is quite specific to help us.
Right. I think it's an oncogene marker, though, isn't it? It indicates some kind of oncogene has formed. I might have a slide on it later. And then we would do cytogenetics. Now, typically we would do fish for these cytogenetics. We used to have to grow them before we invented fish, but now we would say there was a translocation. So if you remember your genomics, translocation between chromosome 11 and chromosome 18 is typical, and trisomy 3 and 18 is typical in MALT lymphomas, and they'll be different for ordinary lymphomas. Okay, so we're going to do...
Could I say that absence of translocation doesn't mean absence of lymphoma either? So
that's right. There can be very tiny microscopic changes that are activating oncogenes. Yeah. Alrighty, should we whip straight into this one?
Yep, common types of lymphoma in the orbit, MALT lymphoma and follicular lymphoma.
Yeah.
Yeah.
Yep.
Let's go.
Okay,
which way are we going to do first? We're going to do
it the other way now,
okay,
where we go straight into this and have a look at this one.
breakout first.
Okay, so that means I have to go to stop share, breakout groups, and I will stop recording while we're in breakout and then come back. Okay, I've remembered to turn on recording. And everyone should be joining us just now. How was that? How did people find that slide? Could you easily tell it was a lacrimal gland? Everyone's quiet. What other things make glands in the orbit? So there's often glands in the skin, isn't there? But I think if you see glands, then it's going to be lacrimal gland, unless you've got skin in the picture as well. I think that's a good rule of thumb. All right, everyone's back.
We are. Okay. Now we have to do modeling. Okay.
All right, so Diane, do we need to say that we would do BCL2 to differentiate benign, atypical versus malignant? And the answer is no. You say the usual things, all right? So let's go through the usual things that indicate it's benign: follicular center formation with tingible body macrophages, a low mitotic rate, no pleomorphism. Yeah. And then you would say you would do flow cytometry to determine whether it's clonal and whether there is activation of some oncogenes, because they can be detected by flow cytometry. And then you would do immunohistochemistry to show it's clonal and whether there's oncogene activation. And then you would say you would do cytogenetics FISH to look for translocations or other oncogenes. And if you wanted to, you could explain that clonality means that there's only one kind of light chain produced and only B cells. But I think you should not go around memorizing any oncogenes.
Lymphoma questions are usually about sending it to the laboratory and doing ancillary studies. It's not about recognizing individual lymphoid cells.
Yeah.
Because we always do extra special studies, and that's the type of thing that you need to know.
All right. Is the kappa lambda ratio important? So usually Reza, the most recent investigator of lymphomas on this thing, is there a cutoff point that we decide whether one is restricted or not?
As far as I remember, not really any cutoff point is which we don't do it that way. But in the clinic, when they measure that, they might use. But in the histology, I never come across of those kind of things based on the cutoff point to say, okay, this is more kappa or lambda. No.
So usually when there's restriction, there's about 80% of one.
80% of one. Okay.
Yeah, I think, but that's just my memory. But if there was 70% of one and 30% of another, you'd also say it was restricted, but usually it's pretty obvious. Yeah, I think. All right. I will go now to the case and we'll have a wee look around. So what were the key features that you pointed out to your people, Amanda, when you were looking at them?
I think it's very important to start with what is the normal tissue before jumping right in and looking up close power at a whole bunch of lymphocytes, which is not helpful. So
yeah, I think group 1 modeled that really well when I was in with them. They definitely searched for the tissue. I'm going to share screen now and share that one. All right, so here we go. Right, I'm just come on, here we are. Right, so there was normal tissue, but like just at the top here there was quite some normal, wasn't there?
Yeah, there's lots of normal tissue. So yeah. And then to identify the components of normal tissue and put it together to find an organ. So I can see the normal tissue here. Looks like the purple cells are acini and of zymogenic granules, probably. And then there was ductal epithelium.
Yeah.
Ducts. Yep.
Here's a duct, his duct.
Yeah. Interspersed by fat. And if we're told that it's in the orbit, then it must be the lacrimal gland. So I can say in the lacrimal gland, there are nodules of lymphoid infiltrate. causing tissue destruction of the lacrimal gland, expansion and destruction. And I think there's like residual epithelial islands, those things here, which would be parts of the residual lacrimal gland, where embedded in a sea of infiltrating lymphocytes. The lymphocytes are small lymphocytes on the small, medium, large scale. They look rather uniform looking.
Yeah.
But I also found around the edges of that nodule some residual lymphoid follicles up in the sort of 11
They were,
o'clock.
weren't they? Yeah.
Because I could see.
Here we go.
Yeah, all over. So around the edges. See, there's that pale area in the middle.
Well, that might be a lymphoepithelial lesion, actually. I think I might have pointed you wrong.
Oh, okay. Over there in that nodule. Oh, yeah, there's one, that pale center. Yeah.
Yeah, there's a good reactive one there. Yeah.
Yeah. And so it's got a follicle center, it's got a mantle around it. Have to go closer to see if there was tingible body macrophages or not. So I can see that there are some.
Probably.
Yep, and there's some little dots I can see. So that would be, I can see a lymphoid follicular architecture here around some edges. So I think that's like a reactive type picture, but the other areas show a tissue destruction type picture. So I've got a combination of both going on here.
So working out that it is benign versus malignant. At low power, we can see it's a destructive infiltrative lesion. Yeah, and then we go to mid power and notice that the architecture is just a sea of cells. Then at high power, we can recognize those little lymphoepithelial lesions where it's actively destroying. And we can see that the cells form this uniform sheet. So those are the key malignant features. But so those are the things that you'd have to remember in the description. And then you'd have to remember the 4 things that we would do. Do you think this needs to be sent fresh, Amanda?
Yes, all lymphomas should be sent fresh.
Because you can't do flow if it's not fresh, and flow is really important.
Yeah, because MALT lymphomas on immunohistochemistry are really not distinguished at all. Terrible to try and to figure out. So if you don't send it for fresh, it's a fail. FF.
And Reza, sometimes we get little tiny bits of tissue, don't we, for lymphoma? Yeah, so what do you think is an ideal size sample for this kind of tumor?
So Diane, I like to receive the whole thing fresh, and I'll chop off a piece and send it for flow cytometry myself.
Yeah, get it all fresh. But sometimes eyes, you can't get I say, tip of the little finger, we want that big. It's quite a big bit in the orbit. Reza,
Yeah.
when would you say it was too small to send for flow and we'd have to put it all in for H&E?
When is, you cannot provide enough first. When it's coming from the lacrimal gland, the point is you have to appreciate and identify the lymph node or possible lymph node, because they are not quite big. As you can see in this slide, they are quite small. First, you have to identify that one, because if you send the sample from the lacrimal gland, it doesn't help. It must be from the lymph node. But for answering your question, if I identify the lymph node and is 5 millimeter less, I'm not going to sacrifice the tissue for flow cytometry. I submit all for histology.
Okay, so we want it sent with more than 5 millimeters. We want you to aim, please, to get the abnormal tissue and not the normal tissue.
Yeah.
We want it all sent fresh. We want, sometimes you can do an FNA, and you can do a washout of the needle and send that for flow. Is that right, Amanda?
Yes, or do a separate pass, like I'm going to do 4 passes and 2 or 3 of them are going to be for flow cytometry, and 1 is going to be to assess for tissue adequacy that we've actually got into the lymphoid. Remember, there's no lymph nodes in the orbit.
Yeah, no. So just this abnormal lymphoid tissue. That was a good discussion. I'm going to stop share and move on to my next slide now.
Regarding keeping the thing in saline and putting it in the fridge overnight, better tissue protection would be RPMI or ask your flow cytometry lab. It's sort of pink stuff. It's got cell food in it. Saline is not so friendly for cells. And we don't recommend any overnight situation. It's got to come the same day. So if it's 4 o'clock on a Friday and you're at your peripheral hospital from the flow cytometry lab, don't do it.
Yeah, Monday morning, please.
Don't do it. You're just
Yeah,
going to ruin the specimen, and we're going to tell you, no good, do it again. So,
Okay, I'll share my next screen now. Right, so the next screen shows, we're going to move on to lacrimal gland neoplasms. So the two lacrimal gland neoplasms you need to know about are pleomorphic and pleomorphic adenoma and adenoid cystic carcinoma. Right, so pleomorphic adenoma, when we look at slides, we have to identify that there are in fact ductular structures that forms little ducts. There are myoepithelial cells which often surround the ductular structures but also spin off into the stroma, and the stroma is often myxoid looking. So myxoid means it looks like very loose looking, and sometimes it forms cartilage and all the cells are bland. Adenoid cystic, by comparison, has got much darker cells and it's a malignant tumor. So you'll find mitoses, though not very many quite often. It infiltrates rather than the pleomorphic adenoma being quite roundy, and you'll find perineural invasion. It has a variety of patterns of growth. It can form round ducts and sheets, but the classic one is the cribriform pattern, and that looks like Swiss cheese. Another food analogy. It looks like the holes in, what's the name of the Swiss cheese, Amanda? That has.
oh yes, I know what you mean.
No.
Somebody told me, I was in the lunchroom the other day, and Paul was having those lotus root chips on his poke bowl.
Yeah,
lotus root chips are cribriform areas.
They're like lotus root chips, and
yes.
It's got two types of stroma. The bright pink one, which is basement membrane like, and also mucoid. So they're both quite complicated tumors to think about. So which is which? So this is a typical pleomorphic adenoid cystic. Adenoid cystic
carcinoma. I've got to put the carcinoma
adenoid cystic
on the
carcinoma.
Carcinoma.
With a nerve bundle here and lots and lots of invasion around it. These are the lotus chips here. Okay,
see what I mean?
Areas, yeah. This is the mucoid area, and then there's heavy dark pink basement membrane like stuff. Well, not well shown in this picture, but probably this pink stuff here. But this is really great for nerve bundles. So we're going to do the bit now where we show you the features and then you go and look at each of them. All right, here we go. So I'm going to go to this benign mixed tumor here, which is another name for pleomorphic adenoma. Alrighty, I guess we have to look for normal areas, and I'm going to think that maybe.
Can you make that?
Yeah, I should be able to make it bigger, shouldn't I?
I think it's the second from the right button, the little arrow out. Yeah, that's the one. Cool. Yeah.
Right, so I'm thinking that this is the abnormal lump here. So maybe this is the normal area here. So here we go.
There's a dark pink and a light pink area, aren't there? Let's investigate.
Let's have a look here.
Oh, and there's some really some lymphoid aggregates as well. Oh
yes,
gosh.
Yeah.
Okay.
All right.
Little ducts. Looks like little ducts to me.
Little ducts. I've lost my. Where's my mouse gone? Lost my mouse. But there's
little ducts, but I've lost the acini. So.
Yeah. All right. Let's have a look over.
And there's lymphoid infiltrates, which are the dark lymphoid fellows. And then over here, now this looks a bit like normal because it looks like globules. It's got a globular structure.
Okay, there we go. Yeah,
that looks better.
That looks much more normal, doesn't it?
Acini and ducts. Yes, little acini and ducts in the center parts.
Yeah, so there's normal, and then over here we've got abnormal areas.
Ooh.
All right. So, what have we got here, Amanda?
It looks very circumscribed to me. I think I could draw my pencil around the edge between the normal, it looks like it's in a lacrimal gland if it's in the orbit, and there's a circumscribed margin, and it's even got a little bit of a fibrous rim around it. And then the tumor, as a mass, is composed of two elements that I can see at low power. I can see an extracellular matrix, which is staining very blue colored, and it's got very few cells. And then there seems to be a cellular area, which is dark staining. And the whole thing is arranged in sort of lobulated pattern. So now I would go and have a closer look at those two components and see what's what. Ooh, well. So the cellular component is composed of these epithelial cells, are cuboidal, and some of them making ducts and some of them making long trabeculae. But they seem to be, and then the second component is this extracellular matrix, and it's got some spindled cells in it, and I can see the cytoplasm is melting into that extracellular matrix, melting. It's hard for me to draw the edges around the cell boundaries. And then I just check around to see if there's any other patterns. But in that field, that looks to me like a pleomorphic adenoma because it's got a stromal pattern and it's got an epithelial pattern. I can see ducts. Let's have a look at some of those ducts. They're not normal ducts, but it's epithelium that's arranged in ductal structures. And I know that can occur in pleomorphic adenoma totally, because that's the epithelial component, makes ducts, sheets, trabeculae, and it's those different patterns. That's why it's called pleomorphic. It's not because it's ugly, it's because they make different patterns. Pleo means different, so different patterns. There's lots, and that's why it's also called in the olden days benign mixed tumor. So it's mixed stromal and epithelial. Stromal epithelial and mixed epithelial patterns.
All right, I'm going to go to the other one now. Here we go.
I didn't see any lotus root chips.
No, there was no lotus root chips there. Here we go. I'm going to go to this one here now.
So that blue stuff was like all in the background melting into it, whereas lotus root chips are no melting, they're quite solid. You can all Google up lotus root chips and have a look on your own screen if you don't know what lotus root chips look like. You can also get them steamed, so are nice and crunchy. Right. Oh,
this one.
Ooh, where are we? Here's the question. What's on the surface? Is that epithelium of some sort? So is that skin? Well, that's blue ink. So
blue ink, yeah.
What about on the top right? Is that top the other side? I need to know where I am.
Skin. It's skin.
Is it where we've got? I need. Okay, I've got epidermis.
Is this the right?
This is very chemetocrosis type.
Yeah, this is not.
Let me find one in my master slide box.
Oh yeah, so, all right, right. It's
down here. Okay.
Yeah, I think we should choose a different one.
Yeah, okay, let's go to master slide box, or we only concentrate on the areas that are more pathognomonic, shall we say?
Yeah.
Yeah, because we don't want to confuse the.
Yeah,
you
I'm just you share one.
Hang on.
And we'll post the link in the chat.
Okay, let me see. Yep, here we go. I think this is the one that's actually in the Kura Cloud lesson, because I think we put one in Kura Cloud. Oh, hang on. Let me just copy that and go up here. Put that there, paste into. Yep, I've got one up. I'll drive and you can navigate me, Diane.
Okay.
Share screen, share. Have we got something?
All right, so normal tissue.
Oh, I'll just move that around so I can see.
We're in Leeds here.
Yeah, right. We're in Leeds. Normal tissue. I'm just going to rotate us because I always like, I don't know. I always like my surfaces out on the top. Anyway, so
it looks like we've got eyelid at the top and skin, and then fat, and then we've got muscle of the eyelid, and we can see some glands there, which is sebaceous glands, but underneath we've got a tumor, haven't we?
Yep. Ooh, this is not normal.
So at low power, I'm trying to identify any normal tissue there. Maybe at the very bottom left-hand corner, there might be a little bit of normal tissue left.
I think maybe that I've got slow rendering. I'm up at the deer farm. So I can see something that would be a lotus root chip here. If it would
Yeah, there's a lotus root chip. Yeah,
it's coming. What I can do is I can put, you've got faster internet. Here's the link in the chat. You can click the link in the chat, Diane.
Okay. And yeah, Leeds is slow anyway.
Yeah, I think we need to replace some of those with subs.
Yeah.
I
think what we might do is how about we get the team get the team looking at the first one, and we'll find a really good adenoid cystic while they look at that.
Okay. Yep. Well, this one's all right down here.
Yeah.
And I think that's probably normal tissue. So that would be
I'll share.
suitably demonstratable.
Okay.
Or else we can all go, we can do breakout rooms and look at, what did we do first? No, we already did a demo. So now we have to do breakout rooms.
Yeah,
now,
so this is working for me. My internet is better.
Perfect.
So here we go. Here's some normal tissue showing its lacrimal glands. We've got probably a central duct, and then we've got acini and a bit of lymphoid tissue. And then we've got all this cribriform lotus root shapes through here. This is the myxoid tissue here. And then where's some basement membrane-like tissue? Probably over here. Right, so this is a different growth pattern, a trabecular growth pattern. And this is the highlight.
Look at that. Wow.
Other growth, other stromal patterns. So this has got a couple of growth patterns. It's got both kinds of stroma. And somewhere in here, there may or may not be perineural invasion. It takes a bit of hunting for, I find, perineural invasion. I think there's some here. These seem to be wrapping round. Are these nerves? No, they're just bits of stroma, but you're looking for these kind of formations where it wraps around stuff.
Okay, I've got a recut club one here. I'll put in there. This is actually a very nice one.
All right, do you want to, I'll stop sharing and you can share.
Okay, so we go into breakout rooms for that one.
Yeah, so if you could put the recut club one on the chat.
Yep, which is a different one.
Yeah, and you guys are going to look at 2 slides in your breakout rooms. You're going to look at the pleomorphic adenoma and the adenoid cystic.
Hopefully recut club's all right. Oh, okay, sign up.
All right, so what is the IHC to look for in these cases? There isn't any. I never use IHC. I just use my eyes.
Recut club
and mucoid, the same thing. So myxoid is what you see down the microscope, and mucoid is what happens on your sticky fingers. Mucoid's a macro description.
Oh, plague one.
Asked for PLAG1. I don't think we've got PLAG1 in our lab. Have we got PLAG1, Rita? Plague 1?
For pleomorphic adenomas, yeah.
No, we don't use it. I have never used it.
No, I think it's because we don't actually have it. But Alice, can you tell us about Plague 1?
That's why I question marked it, because I wasn't sure if it was actually used.
All right, we'll go and look for it.
And it's an oncogene. I think it's an oncogene. Yeah.
An oncoprotein. I'll go have a quick look about that. Alcium blue and PAS need to be done. I never do those either. Okay, so we're going to look at the recut club one and the other one in your breakout groups. Off we go. I'll do breakout rooms, open all rooms, and I'll look up plague 1.
And the proper word is cribriform, not lotus chip.
Yeah. And okay, hello everybody coming back again. I'm looking at the chat, see if anyone's asking questions. Right. And how are you going, Reza?
Good. I was trying to help them to identify perineural invasion, some that they found, and diagnose the cribriform architecture. It was good. It was really good discussion. And
That's good. Can you show us where the perineural invasion is on the adenoid cystic carcinoma slide?
yes, that one was you are showing. You see those three normal tissue within the.
Reza, would you like to share screen and you can point it?
I tried, but it didn't work. Let me
Oh,
try.
is Reza a co-host? Can you do that?
No, I couldn't make you a co-host. I've tried.
And if you go to the lesion, I can easily guide you to find that.
All right, Amanda, Ami. All right.
Yes.
Someone put it up. Someone who was with Reza, put it up.
Yeah, it was the Recut Club one, wasn't it?
Yeah, it was. Yeah.
It was a nice one. Oh, they've got a really dark H&E stain, but there you go.
This one,
Beautiful.
Diane, I didn't see this one. I saw the original one.
Right.
Oh, this one's got really good perineural if you want to see it. So.
Yeah, of course, but because yeah, this one.
This one?
Yeah, no,
Yeah.
that one.
Previous one?
Yeah, this
That
one.
one?
This one.
All right, maybe that's why all right, so where's the perineural invasion?
You come between those at the bottom, 6 o'clock. Yeah, this one, go to the, exact, here. That in the middle, here, a little bit down,
It's
yes,
whirling around something. Yeah.
yes, that one. Go, yeah.
Oh, yay, that's really terrific, isn't it? Yeah.
See, it's like a target. It's telling you, look at me. It's
yeah,
target. Right. That's a nerve end on. That's why they're not long and wavy. That's why end on.
Okay, so this is a transverse section through it?
Yes, that's right. Cross section of a peripheral nerve. Looks a bit like the optic nerve, but without the P receptor.
Yep. And so we're saying that because there's Z cells here, that's the perineural invasion of the
Yep, they're all around that nerve. They're wrapping around the nerve.
Okay.
Okay, so we've been doing this for nearly 2 hours now, and I wonder if we might go, we've tried both ways. I wonder if we might go to the exit survey.
Yeah, okay. Coming to the end. Let me just go to that. And if you've saved these URLs, you can go and look at these yourself with a good textbook, and it'll all be there. Copy. So we'll do the exit survey, then come back and we'll give you instructions for next week. Turn your camera off while you do the exit survey. We really appreciate the exit survey. We read every single word that you say. So we do. So a bit of thought. That's the best thanks that you can give to us, is to put some thought into your exit survey. Turn your camera off while you're doing it, and then turn it back on when you're done, so we know. Completely anonymous, and we don't know who you are.
No, we don't. No.
And you're hidden amongst 24 other people. So do not put your name on it.
Oh, I found out how to make co-host.
Oh, is it another 3 little dot thing? Oh, okay.
I've got to type on the person. Hang on, I've got to type. I think I've got to find the person.
Yes, because only you can do that because you're the host.
All right, so so if I click on you, I can make you the co-host. I'm making you a co-host.
Oh, cool. All right.
All right. And
oh, stop recording.
Oh, thank you. Recording again. And there is this next slide here that we didn't have time to do together, which is the sarcoidosis slide. So if you could look at that on your own, that would be really good. Is there any normal tissue present? I can't see normal tissue present. It's all filled with this dotty stuff. But when I look at it at high power, I might be able to see some normal tissue. So here we've kind of got some normal tissue. We've got some little acini present. And these are the granulomas, these pink things. And in the background, there's a ton of lymphocytes. Okay, a ton of lymphocytes. So this is sarcoidosis of the lacrimal gland in it before it becomes all fibrotic. So these are the granulomas. How do I know that these are granulomas rather than lymphoid follicles? Well, they're full of these cells which have got copious cytoplasm, which are the epithelioid macrophages, and they kind of have these slightly kidney-shaped nuclei. You can imagine them slightly kidney-shaped, but they don't have the really small proliferating cells in normal lymphoid follicles. So at low power, that's the only thing I think you might be able to mistake this for, is that could these be a lymphoid follicle? But if we go closer, we can see that there's some giant cells. The cells have copious cytoplasm and they have reniform nuclei. Okay, so that was the sarcoidosis cell that would be good for you to look at. And then there's a final slide that says, how do I describe this? Okay, so we'll go to how do I describe this? Okay, so here at low power, is there any normal tissue present? There might be some normal tissue present here at the edge, which is orbital soft tissue. It's just normal orbital soft tissue. There's a bit of a lymphoid follicle here, but what we have in the orbit here is a mass. So I'm going at low power architect, a mass that is composed predominantly of fibrous tissue with lymphoid follicles in it. And this dense mass of fibrous tissue could only be one of two things. So it could be fibrosis due to Graves' disease, or it could be actually three things. It could be idiopathic orbital inflammation, or it could be IgG4 disease. And the last two look pretty much exactly the same as each other, IgG4 disease and idiopathic orbital inflammation, because they both end up in fibrosis. And the only way we can tell them apart is by doing immunohistochemistry looking for IgG4. So let's have a look at the fibrotic areas here. This is an AAO slide. And what we've got is these dense hyaline bands of fibrosis interspersed with inflammatory cells. I can see an eosinophil here, but predominantly lymphocytes. And then elsewhere, we've got these lymphoid follicles, which are benign, because, well, they're actually lymphoid patches, there's no really good follicle, they're benign. They contain a variety of cells and they aren't expansile and destructive. And if I did an immunohistochemistry on this and showed that it was predominantly IgG4 expressing lymphoid tissue in here, I'd call it IgG4 disease. Have you got anything to add there, Amanda?
Sounds good to me. Yeah. And I imagine, you know, when you look at you have to answer the question about the clinical correlation. What do you think and feel? What do you think it'll feel like? It's going to be very
hard, isn't it?
Dense,
hard and
fibrous.
Yeah.
Yeah.
This wouldn't feel like a lymphoma, which is like squishy
and soft.
And soft. Other things that might produce fibrosis are metastases, because they can activate fibroblasts as well.
Yeah.
Yeah.
And are there any normal tissues in this?
Yeah, so just this loose fibrous tissue out the side is the loose orbital tissue.
Yeah.
Okay, so good. So that's it, and we'll see you tomorrow.
Sounds good. Excellent.
Great.
Thank you.
Bye, everybody. Thank you so much, Reza, for coming along.
Thank you for inviting me. Thank you. I learned a lot.
Ah, good. That's good. Okay. See you later.
See you all tomorrow.
Bye.
I'll go and feed the deer.
Okay, you go feed the deer. I'll see you tomorrow, Amanda. Bye.
Bye.